services is go through the basic problem-solving process. I come from a manufacturing background, do this all the time. We've taken the first step. We've admitted we have a problem here. So I think the next step is define the problem. If we have time, what's the root cause of that, and then what are the solutions? So, and again, if the first of you gets the definition right, you don't have to redefine it, but I guess I'd like to start with you, Ms. Tinker. How would you define the problem?
What our work showed is that prior authorization was being used at times when original Medicare would have paid for the service.
Do you think just prior authorization itself is the problem, or just not administered properly, or people aren't following the guidelines?
Our work looked at and showed that while prior authorization is useful as a tool in Medicare Advantage, it's that 13% of the time when original Medicare would have in fact paid for those services that created the problem. And our recommendations are really keyed towards how do you make prior authorization work better, and how do you eliminate those times when original Medicare would have paid.
Ms. Fugelston-Binnick, would you agree with that definition, or would you change it slightly?
I agree with most of what Ms. Tinker just said. I would also add that from the perspective of policymakers conducting oversight, I think there is a lack of information to really then narrow in on what types of policies you might propose or other types of oversight you might do, because we don't know the specific services unless you go and get the very detailed data and conduct a very labor-intensive review audit for really who is being affected, how often they're being affected. Are things being denied because they're deemed not medically necessary, or providers aren't providing sufficient documentation? Those lead to very different solutions, and without that information, it's hard to know how to solve the problem.
You got a sub-problem here. You don't have enough information to really define the problem properly and then find solutions. So again, we're honing in on it. I'll give, actually, Ms. Huberty missed this. Ms. Grabert, why don't you, we're going through the problem-solving process trying to figure out what is the definition of this problem. Ms. Grabert.
Yeah, I think there's certainly problems on the fee-for-service side that need to be addressed, because MA plans are using prior authorization to actually get at some of those things. So I don't think the problem is necessarily prior authorization. I think there's some fee-for-service things.
Now, when you say fee-for-service, is that you're going into the private sector, or just fee-for-service describe what you're talking about there.
So fee-for-service is just the option in Medicare that beneficiaries elect that allow them to get services directly without having a plan put together, a package for them.
That's traditional Medicare is what you're talking about then?
Yes.
Okay.
But I would also maybe challenge the 13% number that Megan offered. So 13% doesn't actually seem all that high to me in the way that she's using it. So for example, for inpatient rehab facilities, 19% of what they're billing is actually on the fee-for-service side is an error every year. A lot of the services in the 13% number that Megan used come from an audit for at least 4 of those services were for inpatient rehab facilities. So if you're looking at the 19% that I just mentioned on the fee-for-service side versus 13% on the MA side, I feel a little bit more comfortable with that 13% because it's less error than what we're actually observing for some of those same services on the fee-for-service side.
Ms. Bent, having gone through this, how would you define this problem?
I would say that for my family, when this first came up, I went to Medicare website and looked at what I might expect for my husband. And I saw the figure of 100 days. So I think you can imagine how surprised I was when I was told after a considerably smaller number of days he was going to be discharged. For me, the problem becomes an issue of trust.
Even 100 days is a limit. What would happen after the 100 days? You get discharged to a long-term care facility where there's no hope for rehab? I mean, what's the next step then?
These ladies can all correct me if I'm wrong, but what I read was after 100 days, we would have had the option of leaving him there, and there would have been a copay that came into place.
Well,
So I would have had the option of saying, yes, I can cover this percentage of this fee, and he can stay there.
So, Ms. Huber, do you want to take a crack at how you would define the problem we're dealing with here today?
I think the main issue is that the Advantage plans are deferring the decision-making to a lot of third parties, and none of those third parties are the doctors that are meeting with the patients, or, you know, they're treating therapists. They are rarely even looking at their medical records. Often it is that algorithm that starts the process, and there is very little oversight. They are rubber stamp denial as they go through the process.
So I think you're kind of making the point I was making earlier in terms of our entire healthcare financing system is we're deferring all these decisions to a third party. Right. We're saying we want it all, we want the best, and we don't care what it costs, and that's a problem. So I'll throw out kind of a guideline or an outline of a solution first. Try and reintroduce consumerism into healthcare as best as possible. And from my standpoint, that'd be the low end. You know, the things you can really make a choice on. Say, well, okay, I know I had an MRI last week, and I like another one this week, but it's not worth it, okay? And then have high deductible insurance plans that are actually insurance plans, without the exclusions, without, you know, pre-authorization plans that are being violated and denied. And that's kind of the thought process that goes through my head. But I mean, do y'all acknowledge that it really is a problem, and it can't be because we're spending so much, and in the end people don't care what it's costing because either the government's paying for it up to a point, or insurance care, that's causing costs to run higher than really any other country in the world. That's just a real problem, real issue here. So what I kind of threw out my outline of solution. What are your overall solutions? I'll start with you, Ms. Bent. And by the way, I have all the sympathy in the world because we've had, you know, my in-laws, my parents. My parents fortunately didn't have my mother pass like within 24 hours, a massive stroke, but it was my mother-in-law and father-in-law that just went through and hospitalization after hospitalization and getting booted out before they certainly felt they were ready to go home. And I mean, it's a horrible process, so you have my deepest sympathy. But what do you think?
I would like to see the people who are actually giving the care and know the patient not being overridden in their decisions by a third party that is perhaps using software to make their decisions. And anecdotally, I will tell you that when it was time to stop, my husband's primary care was very clear with him and us about that. He knew when it was time to stop treating and stop pursuing an elongation of something that was not going to change. I think they're trustworthy. I would go with them.
And again, the pushback would be there are going to be some people going to game the system. You know, they might have some financial gain by having people there. But you know, I would agree with you. I think you're making that point. Is we ought to just put trust in the doctors and nurses who are going to abide by the Hippocratic Oath, have the primary responsibility of the patient, not to Medicare, not to Medicare Advantage plan, but let them make the call. I think that's what most Americans would agree with. So then we have to address the cost at a different level then. We got to figure out, you know, how can we, that's where I keep going down to the, you know, higher deductible plans that are true insurance, and you really let the care providers do that, and then try and bring consumers into the process for the little stuff where you do have time. You can make a decision. You can say, okay, I will take the generic drug, or I'll do this. This is going to work, but it's a lot cheaper than that. If that makes sense to you. Ms. Graber, what do you think?
I'm going to stick to my theme on looking at fee-for-service Medicare again, because that's the part of the program that has very little consumerism. So right now, beneficiaries who are in fee-for-service typically elect a Medigap plan for supplemental coverage as a wraparound service for them. There's absolutely no consumerism built into that model because they're shielded from almost all of the costs and out-of-pocket that you're looking at within that model. So Medicare Advantage really is well above fee-for-service in that respect. So if you really want to put consumerism in, I would say target Medigap plans on the fee-for-service side.
What is the cost per enrollee? Again, I don't have this off the top of my head. I'd always heard that Medicare Advantage is really popular because it offers better benefits, but it costs in general the government more because it has that. Is that true?
Yeah, MedPAC estimates this year it's about 106% of what traditional Medicare will spend on similar beneficiaries. It's about $27 billion in 1 year.
Okay. I would have thought maybe it's higher than 6%, but okay.
And, to be fair, enrollees get something for that. They get lower cost sharing, they get extra benefits, but plans also benefit from that. And a key question is how much of the savings they generate should they get to keep? Should enrollees benefit? And should the government get back? And right now the government gets none of it.
So again, what you say, Ms. Graber, is rather than try and pinch pennies and result in the kind of abuses that Ms. Bent had to put up with, you'd rather focus on traditional Medicare and try and bring some kind of consumerism, some kind of cost-saving measures there. Again, you don't want to apply the same thing. You want to figure out a better way of controlling costs. Ms. Huberty, what do you say?
Well, I think we've touched a lot on the differences between what fee-for-service or original Medicare is paying versus Advantage plans. The biggest issue that we're seeing, and that Ms. Ben highlighted too, is that the standards are being applied so drastically differently. If you have an original Medicare plan and you had the situation that she had or a supplement, her husband would not have gone through that. And so there has to be some sort of, oversight or, some sort of, we have to be able to know why they're applying these standards differently and why someone with original Medicare is getting a better benefit than Advantage plan with this particular service.
Again, what standards? Because there is no pre-authorization with fee-for-service. There are standards with the, or is this just simply whether Medicare is going to reimburse regardless whether it's pre-approved? I mean, this is just whether you get reimbursed as a provider. Is that what you're talking about in terms of the standards?
You might be able to speak better to the provider reimbursement, but in terms of standards for a skilled nursing facility stay, it's very basic where if a person needs 5 days a week of physical therapy or any types of therapy, then they get coverage under original Medicare. If they have an Advantage plan, they might get a denial and no one's even looking at the records. No one is even counting the days.
So different question as a consumer, when you get to be an old guy like me, what are you going to choose?
Well, every
right
choice.
Now, I mean, if it was the same plan today, would you take traditional Medicare or would you take Medicare Advantage?
Choosing a health insurance plan is a highly individualized process, and I don't know enough about your medical history. However, what I will say, though, is and this would be to anyone with an Advantage plan, I would say they can be very great and they're important and they do offer those supplemental benefits at times. But if you ever need skilled rehab, the way that Ms. Ben's husband did, to expect this to happen, to absolutely expect it.
Is that the main problem in rehab? Is that really in terms of the definition of our problem here today, is that the main problem?
I am here today to speak on that because our agency has become overwhelmed with these cases to the point that we've started turning them away. And so for me here personally, yes, this is a huge problem for beneficiaries.
We're seeing the baby boom generation.
Right.
You looked like you wanted to say something, Ms. Graber.
I was just going to say I would choose Medicare Advantage today, and I put both of my parents in Medicare Advantage.
Okay. Anybody else have a different opinion than that? Would you also take Medicare Advantage? I don't think you're going to be held to the standard of giving advice to consumers. I'm stalling for time here. I was. No, I really wasn't. So, Mr. Chairman, I was going through the problem-solving process here. Okay, asking them to define the problem. I think we pretty well came to the conclusion that it really is this pre-authorization, not necessarily following the rules. It seems mainly with rehabilitative care is the main issue, and we were kind of starting to talk through some solutions. So, again, I appreciate your absences.